I'd now like to turn to some further discussion of the challenges facing physicians with Medicare payments today and the challenges and opportunities of payment reform. We've heard about that earlier this morning in the context of primary care, smaller physician practices. We're now going to turn to some of the challenges and opportunities for leadership in specialty care, which accounts for most of the healthcare spending in Medicare and also the care for many very serious and life-threatening conditions. To lead that discussion, I'd like to introduce Dr. Kavita Patel, the managing director here at Brookings, who has been leading much of our work on payment reform, particularly for specialty care, and a very distinguished panel. Again, all the bios are in your materials.
Thank you, Mark. Yes, we're not going to, I couldn't do justice to our panelists' bios, so I will do very brief introductions and ask our panelists to go ahead and get mic'd up and mic'd up, watered up. We're in the home stretch, but I think that John, and I wanted to thank the panel that went before us because we couldn't have teed up this conversation more nicely. First, I want to acknowledge and thank the Merkin Initiative for supporting this, and then also want to add a note that while you're only seeing kind of 4 people on this panel today, it's fair to say that in our work that we've been doing for several years now at Brookings, as Mark alluded to, that we've had a chance to work with almost every physician society that's in this room, and certainly those who couldn't be in the room. And what's been very clear, whether it's a discussion about Medicare payment reform or kind of payment reform in general, that there are, a number of examples from the private sector, and I think, again, the congressional panel kind of alluded to how much that's been informing what's happened at the public policy level. But then number 2, that this work is very hard. So while we can talk about bundles and fee-for-service and ACOs and different ways to kind of think about changing the payment levers, having that match to the way you actually clinically have to transform the care and how at the end of the day you meaningfully interact human to human is probably the hardest work. And Darshak alluded, he referenced some of the kind of very important roles that the stories from clinical life can play in informing that policy. And we see it as kind of a feedback loop. And in our work with societies, as well as a number of patient groups and other stakeholders, one thing, it didn't matter what, I'm a general internist, but one thing you hear from anybody, regardless of specialty, is we all know we need to change, but it's very hard for us to see how we do that today. And most doctors have described, and our panelists, I think, can add some really rich perspective to this point of view. Most doctors have described to me that they do feel like they've got one foot on the dock and another in a boat that's just been moving and constantly moving, and that people really want to feel secure and certain about what the future will look like. And there are so many questions, and it's not just the Affordable Care Act and health reform, it's the very nature of what we've been discussing this morning, whether it's more doctors becoming employed, as Farzad and Mark had talked about this morning, and what the implications are, or if it's in terms of clinical practice, how we relate to each other and where the insurance companies, where hospitals, where patients and their interests direct us in terms of policy. So it's more important for us to get to kind of the messaging of our panelists, but then I'd love to also make sure that we get a chance to do some questions. So I'm just going to do some very brief introductions, starting with your left, all the way working down. And again, their full bios are in here, but I'm going to offer, as I normally do, my spirited comments about each one of them because I've had a chance to work with almost all of them. So sitting to your extreme left, but in no ideological order, so I should just say that. We didn't plan it in any way. Dr. John Sprandio, he's the Chief of Medical Oncology and Hematology at Delaware County Memorial Hospital, where he's also the director of the Delaware County Regional Cancer Center, and he has a number of leadership roles as well in terms of his leadership in oncology, and in particular, I think that John's leadership on the medical oncology patient-centered, the medical oncology home, or the patient-centered oncology medical home, has been something that we, in particular at Brookings, have been very interested in. And John's been a very thoughtful clinical practitioner as well as thought leader in this area. Seated next to him is Harold Miller, and Harold probably needs absolutely no introduction to most of you, but he's the president and CEO of the Center for Healthcare Quality and Payment Reform. And when the previous panel was talking about how they've understood kind of the pluses and minuses, the drawbacks and opportunities in payment reform, a lot of that comes from Harold's work over the years. And certainly a number of the physicians that are working in the country, seeing patients every day, have benefited from some of his center's work. Next to him is Anshu Chaudhry. He's the Director of Legislative and Regulatory Policy in the Office of Policy at Blue Cross and Blue Shield Association. And Anshu's really been the Blue Cross and Blue Shield Association, certainly in their representation of membership plans across the country, have been frequently contacted because anything from the alternative quality contract, which some of you may be familiar with in Massachusetts, through some of the efforts around bundled payments that are going on in other parts of the country, have been signature highlights for opportunities to change not just fee-for-service, but to change both clinical and payment kind of reform at the same time, doing very hard work. And I think Anshu's been at the kind of front lines, so to speak, of how you implement this from a policy perspective. And last but not least is a friend of mine, Tom Lewandowski. He's a cardiologist and has been practicing cardiology in Appleton, Wisconsin for a number of years. He's the governor of the Wisconsin chapter of the American College of Cardiology, as well as holding a number of national leadership positions within the college. And I think something that hopefully we'll hear Tom touch on, introduced me to the model known as Smart Care, really taking something that Dan Todd mentioned in the previous panel, the concept of registries, the use of data, and how does that inform point-of-service care in clinical cardiology. And more importantly, Tom's not afraid to make bold statements that might upset and shock his cardiology colleagues, which, given all that's going on with Calculator Gate, I'm surprised you're here, Tom. So I promise I won't ask you about LDL and cholesterol calculators unless there's time left in this. So what I'd like to do is actually, even though they're seated in a particular, I'd love to start with Harold, because Harold, I asked Harold to offer us some general framing comments, and then also in light of the discussion that took place this morning on alternative payment models, I really feel that this panel is the best suited to kind of to ground us in reality. What's really possible, and how hard is it for physicians to do this work? So let's start with Harold, and then we'll work our way through the panel. So thank you.
Thanks, Kavita. Well, I spend a lot of time traveling around the country and talking to physicians and hospitals and purchasers and payers. So I bring you both good news and bad news. The good news is, in talking to physicians, that physicians have, across a whole wide range of specialties, have identified many, many ways to change care for patients that would, in fact, save significant amount of money for Medicare and other payers, and also be good for patients. And you hear a lot of focus on things like chronic disease management, but in oncology and gastroenterology and surgery and a variety of different areas, maternity care, physicians have identified ways for significant savings and improvements in care that I think, frankly, would more than pay for the changes to the SGR without requiring any cuts in fees for anyone else. The bad news is that the fee-for-service system is standing in the way. And I think that people have fundamentally misunderstood the problem with the fee-for-service system. The fee-for-service system poses barriers to change. The fee-for-service system as it exists today doesn't pay for a lot of the things that physicians would need to do that we know would actually be better for patients. So you would actually lose money if you tried to do them, and the fee-for-service system imposes penalties on quality and efficiency. I think at the extreme, physicians don't get paid at all when their patients stay well, which is not exactly a prescription for success in terms of getting better healthcare delivery. So it's not about trying to provide incentives to physicians. I think they have all the right incentives. The issue is creating a payment structure that supports them. The worst news is that what is passing for payment reform in many cases doesn't actually change those fundamental barriers in the fee-for-service system. They put payment changes, putting very small bonus payments on top of the existing fee-for-service system, and attaching an extraordinary number of quality measures attached to that, or providing small shared savings bonuses on what is still the broken fee-for-service system. That's like putting a Band-Aid on cancer and expecting it to somehow be a cure. What's even worse than that, unfortunately, is that even those payment models are being designed in ways that are very difficult to implement. Physicians don't know which patients they're supposed to be accountable for. They don't know what the kinds of standards they're going to be expected to meet until after the fact, with a somewhat of a moving target, or targets that really are not even feasible for them to achieve, and with no change in the basic benefit structure for patients to try to give them the kind of support that they need. The good news, to go back to the good news, is that there are payment models that physicians have been working to develop, what I refer to as accountable medical homes, not just the current version of medical homes, but programs that actually where physicians would take accountability for outcomes that they can take accountability for. Bundled and warranted payments for procedures that would help to reduce the kinds of preventable complications and reduce the cost of those, and condition-based payments. So you actually pay based on the patient's condition, not based on what procedures you do. And the further good news is that there are major specialties working on developing those approaches across the board. Many different specialties and the American Medical Association are working on trying to develop those kinds of payment programs. And I think that they would, in fact, be able to, if implemented, be more than pay for the kinds of offsets needed for the SGR. And fortunately, the legislation that the House and Senate committees have put forward talk about these alternative payment models. The bad news is that those payment models don't exist today. Most private payers are saying they either can't or won't put them in place. And Medicare is saying that it has to test them all first. The problem with testing things is that when you have short-term pilots and demonstrations, is that it's very difficult for physician practices to really make the kind of dramatic changes that they need to make with something that is uncertain about its ability to continue. And I find it kind of odd that we're talking about trying to test new payment models. Whenever you look back at all of the major payment systems that exist today were put in place without testing. The inpatient prospective payment system, DRGs, was implemented 14 months after Congress enacted it with no testing whatsoever. The RBRVS system was enacted in a phased-in over a 5-year period with no testing. The outpatient prospective payment system was put in place with no testing. It was because they were viewed as good ideas that would have to evolve. So it doesn't mean that you know exactly how they're going to work up front. You have to evolve them over time. And the physicians who have developed these ideas really right now do not have a good way to bring them forward, because we have a very top-down approach to payment reform in the country. That it's going to be decided in Washington what the payment model is going to be, the physicians have to implement. And you know, it's not the way we do things in any other industry in America. In every other industry, we celebrate entrepreneurship. We say that small businesses should develop a new idea about how to improve things and deliver better value. They go to a bank, they bring a business plan to the bank, they get a loan, and they go out and they implement the idea, and they're accountable for being able to make it work. We need to have that same kind of an approach in healthcare, is to say that when physicians have good ideas about what to do and are willing to take accountability for making them work, to bring them forward and be able to put them in place, but to get the kind of support that they need. And I think that's the final piece of this puzzle, is to being able to give physicians the kind of help that they need, which is very difficult to get. They cannot get access to the data that they need to be able to put that business plan together. Because you do have to be able to cost it out and make sure that it works effectively. They need technical assistance to be able to change. And it's not because they don't know what to do, but as many people have said, it's like trying to fix the airplane while it's in flight, is that they're busy trying to take care of patients, and it's very difficult to try to change your practice along the way. And they need help with patient education and engagement. And we have organizations all around the country that are working on a multi-stakeholder regional health improvement collaboratives that are actually working to try to help physicians do these things, but they get no federal support to be able to put them in place. And I think that if we would provide more support to them and data and analytic support, physicians would be able to rapidly accelerate what they're doing and make these kinds of programs successful, better care for patients, lower spending for Medicare, and be better for physicians and keep more physicians in practice and have the joy of practice that they entered medical school to have.
That's wonderful. Thank you. And I think we'll get in the Q&A. I know I want to kind of circle back and ask you for maybe a couple of from your experience, some examples where just that regional effort, as well as I think your message is an important one, that it's unfunded. I mean, in our current system, they're doing this because it's the right thing to do, and they want to see something change, but they're constantly working against the grain of
the barriers
of financial
that are critical.
incentives.
It's not the need for bonuses.
Right. Let's segue actually then, John, this actually sets you up nicely with some of what you've struggled with as well as where you've seen some success. Can you go ahead and give us just an overview of your work to date and how you see this in the larger scheme of payment reform?
Sure. Harold gave a great overview with some good news and bad news, but being hardwired as a medical oncologist, I heard mostly good news. Because I do think that value, people are going to respond, payers are going to respond, and patients will respond to value-based care. It's kind of funny that it's the 10th anniversary of the MMA. The MMA was really a watershed moment for me personally and professionally, changed our strategy considerably. Over the last 4 years, I've been introduced, or 4 years ago, I was introduced as a pioneer for oncology patient-centered medical home. Last week I was introduced, I must have aged because I was introduced as the grandfather of the oncology patient-centered medical home. And since Mark was responsible for the MMA, he must be one of the great-grandfathers of oncology patient-centered medical home. But basically, I'm an independent practitioner from the Philadelphia area. And what we did, really it was after the passage of the MMA, was realize that we had to create a new value proposition if we wanted to continue to serve our patients in the way that we had under the previous payment methodologies, which were set in motion to change on the basis of the MMA. I might add appropriately change. So we really tried to differentiate ourselves in the marketplace. I resigned from a larger organization that was trying to bring together 26 practices and 2 academic centers to really look at quality and start measuring data. We didn't have the data systems. So after the MMA was passed, I forego the outside goals of working with a larger group and concentrated on our practice. So we implemented an EMR in 2004. We created software that really allowed patient and physician efficiencies and really collected data on a real-time basis that was really focused on looking at potentially avoidable complications, identifying and then reducing potentially avoidable complications. So a few years later, the NCQA standards came out. We realized we met them and we applied. And we were recognized in 2010. Over the years, with the incremental changes that we've made in the way that we executed care, always trying to execute more consistently across 4 sites and 10 physicians, which is not a big group, we really were able to progressively impact our resource utilization. Significant reduction in ER visits per chemo patient per year, admissions per chemo patient per year. We increased our hospice length of stay, and so on. We got better in terms of executing survivorship care plans. We had better coordination with our primary care physicians and the other treating specialists who were involved in the cases. So we captured a lot of attention. Now, how does that fit into healthcare reform? Well, healthcare reform really is all about value and demonstration of results. And there's been some fundamental questions raised by some very accomplished people regarding how do we actually execute and deliver care. Dr. Kim, the former president of Dartmouth, when they initiated the Dartmouth Institute for Healthcare Delivery, stated that the real rocket science is cost and quality. It's really not the bonus and the tremendous amount of information we're going to have access to regarding molecular testing and so on. It's really how do you execute care? And the reasons behind his comments are really magnified when it comes to oncology. We have great basic science, we have great translational research, we have a tremendous number of organizations who have done a really good job in terms of directing providers and patients on the proper ways of addressing their individual problems. But the fundamental question of how do you execute care has not really been studied, and we think that this model addresses some of those issues. The ACOs continue to evolve across the country. There's over 440 ACOs that are in phases of development, and as they mature and as they develop out their models, they're looking to oncologists or cancer care providers because they're faced with solving a dilemma of a low volume, high cost, unpredictable care item when it comes to cancer care. So there's been a call to specialists, oncologists in this case, to really step up and be responsible for redesigning care. And oncology has really responded very favorably. Multiple specialty societies have taken the model and brought in additional stakeholders, developed different standards and so on, and it's moving ahead. And I think that's one of the reasons that this really fits in well with the SGR effort. The alternative payment models, practices that really transform, specialty practices that transform, I believe, will be well positioned to participate in any alternative payment methodology that might come down the pike. When you control the consistency of execution of care and the payer and patient and provider-centric outcomes in each specialty, you become enabled to really participate in different contractual models. So I am optimistic. I really don't fear the different contractual models. I would embrace them. And we look forward to changing the way that we deliver care and execute care more consistently for this vulnerable patient population.
Great, thank you, John. And just a very brief follow-up. So given what your knowledge is of the Senate and House frameworks, would what you did in the suburbs of Pennsylvania, would that fit into an alternative payment model?
Yes.
Okay, good
Yes.
to know. And
It's the basic work on the physician work environment, changing the redesign of the physician work environment that enables practices to participate in these different models.
great. Tom, shift to you and talk a little bit about cardiology as well as the opportunities that and some of the barriers. I think it would be great to get your perspective from what you've been doing personally as well as how you see this in terms of the national leadership role in cardiology.
Trying to think of how to approach this to really give you all a feel for what's really going on out there and what really fundamentally needs to change. As a member of the American College of Cardiology, which has a very long tradition of studying what it is we do as cardiologists, what are the things that are working well, what are the things that are working poorly, and then learning from that information. Very rich registries coming now to take those registries and turn them into tools that can be used at the point of care to help a clinician not only take guidelines, but to then take these generalized guidelines for a population and help you look at it so that when you make that judgment call for that one individual patient, that you make what is probably the best decision for them and you know what else could happen. Now, the interesting thing about that is in our state being very progressive and setting up many other ways of looking at differences in the way healthcare is provided, we started with a all-payers database, and from that, we started seeing behavior changing based upon what people's utilization of resources were, based upon the cost structure only. The problem that came about because of that is, as a cardiologist, we found that there was very wide variation in the way that we provided care around an acute myocardial infarction or a heart attack. The problem that became even greater is that people were therefore making decisions on the intent of the people providing the work. And because there was wide variation that these guys way over here, very high cost, must be doing things that aren't necessary. Well, the reality is, as a cardiologist, I realize not all heart attacks, even in the same artery, are the same. And so part of what we had to realize is that not all variation is bad. But what we have to be able to figure out is what variation within that variation is appropriate and what variation is not. That means that we had to start by looking at angioplasty and trying to decide, is there a better way of approaching this? Everybody focused on that angioplasty because it's a very high-ticket item. Not only that, we have lots of people who end up very popular to put cardiologists out there for doing inappropriate angioplasties. I can tell you that when I go around my state, Florida, and the nation, I don't find any cardiologist who believes that any stent that they put in was inappropriate. So to some extent, there are flavors within that patient which makes people make the decisions they have. And as we've heard earlier today, everybody was pointing, well, it's their fault. Oh, it's their fault. Oh, it's their fault. I can tell you that when we say cardiovascular costs are skyrocketing and it's the specialist's fault, that's where I'm going to look at you and say, stop. Everybody is involved in there. Because in order to fix the angioplasty problem, you have to go, how did the patient get to the cath lab? Well, how did the patient get to the person who sent him to the cath lab? Well, how did the patient get to the stress test? Well, who ordered the stress test? Well, what did the primary care physician hear? And what does the patient coming at it? So as you've looked at the SGR construct, all of the aspects that are in there, patient engagement, getting the actual data at the site of care, all of those are possible today and can be done. So we looked at a way of doing this and actually then sort of looking at it and saying, okay, in the state of Wisconsin, even though because of the all-payers database, they believe that cardiologists were responsible for all the care, the cardiologist only represented 4.7% of the total spend. Primary care specialties were representing 4.7% of the total spend in cardiovascular medicine. When you look at the imaging studies that start the cardiovascular process in motion for an angioplasty, by the Medicare data from 2012, more than 50% of those studies are ordered by the primary care community. But they're attributed to the cardiologist because we're the ones who ultimately read it and bill for it. And so one of the problems that we have with the data that's out there is, well, it's important data, it's the wrong data. So we started approaching this and saying, well, let's kind of throw everything out. Let's take a look at quality. We all know the cost has to go down. We all know the dollar amount that's out there to pay for it is not getting any bigger. So how do we therefore make sure that the quality of care we expect will be there for the cost we have? And the problem we saw was people were approaching it by saying, here's the amount of money we have, what kind of quality can you give me? We flipped it around and said, I'm that patient. What kind of quality do I want, and how do I know that I'm getting that quality? And then say to the people designing the payment in the system, now design around that. We know what we want, how we want to judge it. We want the cardiologist to be working very closely with primary care. There are too many patients. There are not enough primary care doctors. There's not enough specialists. We're not going to be able to lick this problem by having one specialty taking it on versus another. We're all in this boat together. And so from that standpoint, I caution people when we start talking about providers. When you talk in Washington and in policy, please start using the terms that are more specific, because to a cardiologist, a provider is a cardiologist. Mm-hmm. To a nurse, she's the provider. To a hospital system, they're the provider. So when we talk about programs, we have to be specific on who's got the ownership, who's doing the work, and what work are they doing. And then moving forward and getting all of those providers, no matter what their titles are, to work in the most efficient manner for that patient. get them to the clinician who can do the best work for them as fast as possible. Now, in cardiology, we represent a very large dollar amount. So while we all talk about moving from volume to value, I can tell you that in the states of Wisconsin and Florida, the clinicians are ready. We've been ready for 3 years. But now we have hospital systems, insurers, and even payers all looking at each other and saying, you go first. You go first. So when Harold talks about the momentum in fee-for-service setting up barriers, it's real. If we were to implement smart care on angioplasty alone, there's potential of decreasing not only the stress studies, not only the diagnostic catheterizations, but also the angioplasties down to about 40% from where they're down 40% from their current levels. When you add that all up, that's billions of dollars across the country on a yearly basis. The hospital systems, without a payment reform, cannot take that on.
Tom, can you just give a kind of a snapshot of smart care for people who may not know what that
Smart care
program
is a program
Right.
which goes back through all the different steps I talked about as a patient works through chest pain. And in each of those steps, there are decisions that are made. So providing each of those individuals tools to help them make the best choice as they're moving through the process. So rather than focusing on the end product of the angioplasty and only holding accountable the interventionalist for all that work, actually having all the clinicians involved who are using tools being accountable by actually grading them on what they're doing. What does the guideline say? What did you choose to do? And then what was the outcome? Then paying for that outcome. And then adding to what Harold said, a warranty. So paying one fee for all that work, no matter what you do, for 6 months. And then giving bonuses for outcomes, adjustments for the severity of those patients that you took care of, not based upon actuarial data, but based upon the data that's within the registries.
Great, and now, Anshu, you're going to fix all of it by changing every contract that you've ever had with payers. But in truth, give us some examples as well as where I think it's fair to say that a theme that's come up, whether it's Medicare as a payer or Blue Cross Blue Shield or any number of payers, that so much of the ability to change the way we're practicing is bound by how we're paying for it. So give us some examples and then also your perspectives on where you can see some of this alignment between all these different payers and kind of the practical reality of doing this on the ground.
Sure. Years before the Affordable Care Act put a lot of these delivery system reforms in motion, our plan started to see some of the value in transitioning towards value-based programs. Our work started in this space, I'd say in earnest back in 2005. The American College of Physicians approached us and asked us if we'd be willing to test out the medical home concept and looking at a way to transform the way that primary care was delivered and financed. And then those initial conversations really helped open the door to additional conversations with the other primary care specialties, so the American Academy of Family Physicians, the pediatricians, osteopathic physicians, and eventually that expanded out to the employer community and policymakers, and trying to advance this concept of value-based programs or delivery system reform in both the private and public sectors. In general, our plans have taken a two-part approach to structuring these alternative payment models with the physician community. First and most obviously, we're changing the way that we pay providers. In medical home models, which have been very common across the country now, it's sort of a hybrid approach that is probably familiar to most of you, where there's an upfront care management fee or it's called sometimes a capitated fee or an enhanced per member per month fee, which helps try to cover some of the costs of the investments in transformation, as well as the services that fall outside the face-to-face visit. Second to that is fee-for-service, which hasn't gone away, but for the face-to-face encounters. And then on the back end, there's this reward payment or a quality incentive payment. ACO types of models are seeing a slightly more dramatic shift away from fee-for-service in these multi-year contracts. So looking at typically 3 to 5 year arrangements where the reliance on fee-for-service goes away over time. And there's a similar sort of three-part model where there's that fee-for-service component, a quality and outcomes-based performance, and a total cost of care component. So providers can share in the savings based on hitting quality and cost outcomes. As we've heard today, the challenge to reform payment, it's great enough, and the markets are complex enough that there's no real single solution to this. For medical homes, our Blue Cross Blue Shield plans across the country, we have activity in 48 states, DC, Puerto Rico, and it's covering over 8 million lives. And plans have started to see some positive results from these different models. Two of our larger programs that I'll just highlight briefly, Blue Cross Blue Shield in Michigan, their program has over 1 million patients in their medical home, and they've been at this since about 2007, 2008. And their particular program actually has been a great example of an evolution over time where it started off as a pay-for-performance program. They worked with the physician community and the stakeholders in the state to build in this medical home component. And then in, I'd say probably about 2010, they built in these on top of the medical home and on top of the pay-for-performance, organized systems of care, which essentially is what they're calling their ACO program. And so it's taking multiple levels or evolutions of this transformation and getting away from conflicting or competing demands or additional burden on providers and layering different pieces on top of one another. And just recently, this summer, they published in Health Services Research over the course of the last 3 years, they were able to demonstrate $155 million in savings. They, across the board in all the clinical quality metrics, they've seen improvements for some of the chronic conditions, as well as preventable emergency room use dropped by 9% over the last 3 years. Generic prescribing rates have gone up, and taking a closer look at high-tech imaging, that's also dropped over the last few years as well. Care First, Blue Cross Blue Shield here locally, they also have had significant success in the couple years that their program's been in place. They launched back in, or actually, they recently completed the last two-year look at their program, and this summer they mentioned that the estimated costs for the 1 million members that are in their medical home program were $98 million less than what they'd expected based on past claims history. And so providers that were participating in the program, 2/3 of them across the Maryland, DC, and Virginia area were able to, they achieved quality incentive rewards, and their quality metrics were higher across the board as well. Looking at shifting at ACOs, and a couple of the programs that I'll mention here that take some of the total cost of care approach, which builds in quality outcomes as well, and a shift away from fee-for-service. Blue Cross Blue Shield of Massachusetts and the Alternative Quality Contract, which many of you are probably familiar with, published in Health Affairs last year. Blue Cross Blue Shield Massachusetts program showed in the first year a 2% reduction in the cost trend, which equated to about $10 million in savings. And then in the second year of the program, the spending was about a little more than 3% less than the providers that were not in the Alternative Quality Contract. What's been key in Massachusetts as well, it started off as a voluntary program. So providers were not forced into this program. It started off as optional, and as we heard earlier today, when providers had the choice of fee-for-service as it was, and with no additional updates, or an alternative path, today in Massachusetts, 80% of their providers, Blue Cross Blue Shield of Massachusetts contract providers, are in the Alternative Quality Contract now. So providers have seen over the course of the last couple of years that there are some other opportunities there to, even though payment is changing, they can still be made whole, and in some cases actually gain additional income as a result of that. And in Minnesota, another example is the Aligned Incentives Contracting Program that our plan there has in place for the last couple of years. 2011, they were able to demonstrate that for those providers that were in their total cost of care program, expected costs were about 34% less than comparable systems that were not. About 75% of the providers in that particular program received outcomes incentives awards. And similar to the other programs, we saw positive improvements in quality outcomes for the chronic condition metrics. So as I focused on payment these last couple of minutes here, the other piece to that is really changing the way that we partner with the physician and the provider community. It's more than just tweaking the contract and just putting money on the table and saying, okay, now look, you're accountable for this. As we've worked with providers, you've heard earlier today that everyone's starting from a different place, and you have to meet providers where they are, and that's extremely true. The needs of a small practice are going to be very different than the needs of a larger multi-specialty practice or a larger group practice. And so, trying to provide individualized supports that can be tailored to the practice needs. One of the big assets that we have is data, and providing that data in a meaningful format for physicians to help them with clinical decision support at the point of care, but then also in managing population health. Providing nurse care manager support. In some cases, as practices are transforming, there's a huge cultural shift, and in some, having a nurse care manager that can help with care coordination across multiple settings, and that can also assist with some of the practice redesign. We've found that practices in certain parts of the country, they've welcomed that, and that's been very helpful in that evolution to becoming more patient-centered and more accountable in their care. And then also, as I mentioned, data and the nurse care managers. We're also looking at, in certain places, it's still an evolving area, but integration of pharmacy support and behavioral health supports. And those are also big needs. And I think that still needs to be expanded more, but we're looking to do that. As Kavita had mentioned, looking at alignment with, with other payers and how can we streamline this and try and get some scale and consistency of approaches. We're participating with Medicare right now in the comprehensive primary care initiatives, and so we're happy that in the 7 CPCI regions, Blue plans were the only payers selected to participate with CMS in all 7 regions, and so we're starting to see some alignment there. And when you take the scale of Medicare, you've got the Blues, 1 in 3 Americans are covered by Blue Cross Blue Shield plans. You've got significant scale there. We can take some of these concepts that the private sector has already tested out, build it with some of the concepts that Medicare would like to test out, and hopefully have a more sustainable program longer term. We've also been participating in multi-payer initiatives with other commercial payers over the last few years in various states. And I think, in those particular programs, what's been helpful is having the state or an insurance commissioner, some sort of convener at the table that can help with some of the antitrust concerns, and especially when you get into issues like pricing. And it helps bring the payers together, set some ground rules, and while there's not always a similar approach to payment, there might not be the exact same dollar amount that's paid out, but there's a range that's usually agreed upon there. And same thing with measures as well. And so we've heard and time and time again, just the administrative burden on physicians these days with the number of conflicting reporting entities and requirements for multiple different payers. Through some of these multi-payer initiatives, what we've seen is that there can be a core set of measures that are selected and agreed upon with the physician community as well as with the payers at the table. And then going beyond that, payers can still continue to work, build in incentives with physicians that may go beyond what was the specific focus of that particular initiative to customize it.
Great, thank you. So I know we're going to have a number of questions. I want to ask anyone from the panel to respond. Something that we heard a little bit about this morning, Farzad kind of mentioned smaller practices. We've heard this in a number of settings outside of here today. Since the majority of our country is still delivering care, sometimes even, John, you reference your own practice and kind of doing that with 10 physicians or less than 10 across the country. How do we think about some of what we've discussed in the context of smaller practices? And then I also bring all of us, trained in some academic institution. There's the experiment going on in California with reference pricing, which has challenged some of the academic institutions in that state and dealt first-handedly with this issue of kind of what are you paying for when you're asking for the same arthroplasty that was, $33,000 in one and $67,000 in another, simply because of the academic affiliation. So those are 2 areas that tend to come up in our work at Brookings when people are talking about payment reforms. Just any thoughts from any of the panelists and their experience around small practices or even the larger academic settings?
Well, I would say that it's a total myth that small practices can't do these things. The earliest documented example of anybody giving a warranty in healthcare was a single orthopedic surgeon in Lansing, Michigan, who said, I'm going to give a 2-year warranty, and it's in the literature.
Yeah.
Doctor made more money, health plan saved money, hospital made more money. And I think you see that across the board. Now, there need to be mechanisms to help them move in that direction, and they may need to partner with other practices to be able to do it, but it depends critically on having a payment model that is structured in a way that supports them. And too many of the payment systems that are being structured try to put a total cost of care accountability on a single primary care practice, which is just completely inappropriate. What we need to do is to have individual specialties being able to take accountability for the things that they can take accountability for. The other side of this is that we have to be thinking about the hospitals. And if we're actually going to be, where's the money going to come from? It's coming out of hospitals. Physicians only represent 16% of Medicare spending. The 84% is in hospitals and post-acute care, et cetera. But we expect hospitals to be sitting there at the ready with an emergency room, with a burn unit, with a psychiatric unit, with a NICU to be able to deal with all of those cases. And so they need help in transitioning. And your academic medical center question is just another example that we can't base teaching and research payments on fee-for-service volume, because that's how academic medical centers are paid today. So we've got to be able to take them off of the fee-for-service structure too, and be able to pay for those things separately, and then help hospitals make the transition so that all of that fixed cost that they build up, because we've been telling them we want them to have, more machines and more equipment and more surgeries and procedures, and help them be able to phase that down to be able to get to lower spending in a way that doesn't decimate the viability of the healthcare system.
Well put. Any thoughts? Anyone else? John, and we'll work our way down.
I would agree with Harold. I think that the size of the practice really doesn't matter. It does matter if they're going to take on some risk. There will be some consolidation to do that. But I really look at the PCMH principles as being broadly applicable and almost universally applicable to independent practices and academic centers. We're party to an NCQA grant in southeastern Pennsylvania that is planning to transform 10 academic sites and 5 academic sites and 5 private practice sites. So it's really, I think that the redesigning of care, the changing in processes, the collection of data, the loop of continuous process improvement is applicable to practices at any size.
Anshu?
Yeah, I think that I agree with Harold and John's comments, and I think that it does help though if the incentives are large enough for for practices to take on.
Have you seen when some of the you've mentioned like some of the success of some of these initiatives already? I know firsthand, at least with Care First, a lot of these are with small practices.
Exactly.
Did you what's the right number? I mean, where do you find a threshold above which small practices say, yes, we can do this?
It's I don't think we've discovered the magic number yet for, say, for medical homes in particular. I know going back to some of our pay-for-performance experience, from years ago, what we found at that time was that if at least 10 to 15% of revenue was not affected by it, people weren't going to want to participate.
It wasn't enough.
And
right.
So, I think with these alternative payment models, changing the financial incentives are important, putting the structural support there as well. MGMA published a statistic earlier this year saying that for each full-time physician, FTE, it costs about $100,000 to transform to a full-scale medical home, which that includes the acquisition of electronic medical record and technology. So if you're looking at $100,000 per physician to become a medical home, the costs are going to be significant for practices, particularly smaller practices, to take that kind of responsibility on. And one approach that we've seen that, and particularly in Michigan and in Care First, is this concept of virtual panels where while it originally started as a way to increase or create a sense of shared accountability across primary care specialists and hospitals, where you have the fee-for-service system, which it's reimbursing the physician for an individual encounter, but then there's the back end of these alternative payment models, which are based on total population health, and so physicians are being held accountable for care that a lot of times is outside of their visits, and they may not always know the providers that the patients are going to get. They're being held accountable to that. So this concept of virtual panels came up where primary care practices were asked to align with specialists and with hospitals, come together and form a panel that may not share 4 walls, but together they're sharing accountability for the care of a group of a defined population. And that's a way that smaller practices also have been able to achieve some of the efficiencies as far as some of the upfront infrastructure and the resources, where they're able to leverage that from some of their other physician partners that are out there through this shared responsibility.
I have to say, though, that we are in most of these programs trying to load up entirely too many requirements on physicians before they can get into any of these models.
Yeah.
As soon as we even talk about anything, primary care medical homes or ACOs or anything, immediately rush in with huge accreditation standards that you have to do all this stuff. You have to have massive infrastructure and IT systems before you can do anything. And the practical matter is that is not true. And in fact, if we would allow people to transition to that over time, we would be able to get significant savings up front and then be able to build those capabilities over time. So if you bring people in a room and say, what do they have to do before we pay them differently? People come up with very long lists of all these ideal structures. But most people don't really need all of that to be able to change the way they deliver care. What they need is a different payment model to enable them to give them the flexibility to change the way they deliver care and the accountability for costs.
And Kavita, in Wisconsin, we look at it a little bit differently. It's not,
you
know,
always
what
do
is,
in Wisconsin.
I know. You know, it's
think
got
that's
something
actually
to do
a
with
state thing.
walking around
yeah,
with
exactly.
cheese heads. But, you know, another way to look at it is not necessarily by the percentage of the payment, but the percentage of the patient population there.
Yeah.
So, you know, you can have
Yeah.
1/3, 1/3, 1/3 in different payers, but if everybody's doing it consistently, now it makes sense for that practice to do it. So one of the problems that we've all talked about is, you know, United does it one way, Blue Cross Blue Shield does it another, Medicare does it another, Medicaid does it another. So we've approached all the other payers, the private payers, Medicaid, we're approaching the state payers. And so we've gotten to a point where we have over 40% of the insured population in the state now standing behind this concept and saying, it makes sense. Well, when you reach that critical point, as Harold says, people will do it and they will change whether you paid them more or not.
Is there a question, are there questions? I know we need to wrap up, but if Mark's giving me the great-grandfather of the MMA has given me 5 more minutes. Are there anybody in the audience with any questions? And if we can get a mic to the lady in the back. And just, if you don't mind, your name and where you're from.
Sandy Marks with the American Medical Association. Thanks, that was all really great presentations. I've been puzzled as people talk about ACOs, particularly ACOs, but also other models. The patient assignment is based on primary care visits, and you all are talking about specialty models. How do you get there? How do you get the oncology community involved in ACOs when the patients are assigned to the ACO based on their primary care visits? And, you know, similarly with cardiology, I just don't really understand how to make this work for specialists in a way that patients are really getting integrated care where all their physicians, primary care and specialists are working in the same direction.
Well, my answer to that is that you build the ACO from the bottom up rather than the top down. We are doing ACOs from the top down. We're saying, okay, everybody come together, and then we'll attribute patients to you based on primary care, and then somehow whoever happens to have those patients is suddenly accountable. As opposed to saying, let's actually say to the patient, who's your cardiologist? Who's your oncologist? Who's your orthopedic surgeon? Have them take accountability for the patients that they say are, those are the doctors that are managing me, and then have those physicians come together to work to manage the overall cost and quality for that patient population. That's building the accountable care organization from the bottom up. And if you have every physician taking accountability for the piece of the puzzle that they can take accountability for, PCPs are responsible for things that PCPs can be responsible for, preventable emergency room visits, et cetera. Oncologists are accountable for trying to make sure that patients don't have ER visits and hospitalizations for dehydration due to chemotherapy reactions and nausea. Cardiologists are responsible for the piece that they have. Then all of a sudden, those physicians collectively can actually take accountability for total costs and be paid on a global payment basis. But we're going at it in exactly the opposite direction. We're saying you're going to all keep getting paid fee for service. And somehow there'll be a shared savings payment if you magically, collectively, when you don't even know how to work with each other yet, figure out how to do that. You build it from each specialty up.
Anyone else? I know, certainly we've been looking at this exact same issue kind of in oncology and cardiology because as people have been talking about oncology ACOs, for example, the question has come in the current Medicare ACO format. What you described, Harold, is very difficult to do for the very reason you pointed out. But John, Tom?
Regarding oncology, I don't see the real need for oncology ACOs in every market. I think they might serve a purpose in certain markets, but oncology practices are able to have contractual relationships with multiple ACOs. And presumably they're going to be selected to work within that ACO umbrella based on value, which is really quality and cost.
I think one of the problems that we've run into is that as we've moved forward with payment reform, is that rather than looking at it from a global perspective, in Wisconsin, the great example of this is when the state discusses manpower shortages and we only talk about primary care physicians when we will have a shortage of nurse practitioners, PAs, cardiologists, orthopedic surgeons in the near future. When we start funding things, we have to be careful when we talk about primary care and medical home. Primary care and specialists, we're all tied together, whether we like to all admit it or not. We are all dependent on each other, and we need to start behaving that way. And frankly, when we're designing these systems, we need to be more flexible in what is primary care. Because for somebody who has renal disease and is on dialysis, their primary care physician is that nephrologist who they see all the time. For the end-stage heart failure patient who's being worked up for a transplant, that's the cardiologist, the transplant cardiologist. And the reality is we all have to work together and start leveraging our strengths together and finding ways to really encourage that.
And I think it's a fundamental problem to say that we're going to completely change the way we deliver and pay for care and not have the patients even know they're in a different system.
Right.
If we think
if we haven't even had,
if we think that ACOs are good, then patients should sign up for them. Instead, Medicare warns them about it. Beware, you're in an ACO. And that's not a good way for physicians and their patients to work together. Patients should say, I want to be in this, and because they know they're going to get better care.
They know it's getting better care. Yeah. Right. Well, let's, if our panelists will indulge us and be able to stay afterwards, I want to make sure we at least keep to time. And join me in thanking them for a great discussion. If you all just want to stay there, then Mark, close it out. Okay, perfect.
So we've just got another minute more. I want to thank everyone for joining us today and for discussing a wide range of issues critical for moving Medicare physician payment reform forward. You heard about a lot of issues in getting to payment for physicians that is better aligned with the care that they want to provide. The bad news, as Harold put it, is that this is hard and that the vicious cycle of short-term SGR fixes, which is very frustrating for clinicians, is not going to get any easier. The good news is that you heard about a lot of very promising paths forward, all starting with identifying ways for clinicians, physicians, and other healthcare providers to improve care in primary care and specialty care, and then finding ways to support and sustain these efforts in Medicare payment reform. So what is clear is that physician and clinician leadership is essential, not just for this Medicare legislative process to succeed, but more importantly, for real healthcare reform to succeed. And this means not just paying more for more expansions of coverage, but for actually getting to better, more personalized, and preventive care that is more affordable and therefore more sustainable. The leadership that's reflected here today, you heard from a lot of physicians, physicians from Congress, physicians here at Brookings, and point out that every single panel that you heard from today was led by a physician, and most importantly, physicians who are leading real healthcare reform around the country are working together to change that. So there will be a webcast available online from this event for those of you who didn't already see it on the web and want to get more information. We've also made available a lot of associated materials on SGR reform and the path forward in payment reform that starts with improvements in clinical care on our website. And as Darshak pointed out, tweets available at #BrookingsMed. I want to thank as well the Richard Merkin Initiative on payment reform and clinical leadership for providing some of the financial support for our effort today, and a special thanks to our Brookings staff that made this all possible. Dr. Farzad Masashari, Dr. Darshak Sanghavi, Dr. John O'Shea, Dr. Kavita Patel, Joanna Klatzman, Sarah Bleiberg, future Dr. Jeffrey Nadell, and Christina Flores. But especially thank you all for joining us, and please stay tuned. Much more to come, and hopefully soon, on these critical issues for real healthcare reform. Thank you.